always bumps them up to a level 3. If you say take Tylenol, take Motrin, take Sudafed, take Benadryl, take Claritin, once you tell them to take that, you have elevated their risk up to a level 3 patient. Just that quick. If you tell somebody to do physical therapy or occupational therapy, whether it's a referral or if you just say wrap that ankle, that is elevating them up to that level of risk, which is low, which is level 3 patient. Or if you give them IV fluids, like in the office, that's not that big a deal. That's level 3 also. If you do pre-op for surgery and they don't have any known risk factors, all these things will make them a level 3. These next 3 slides, this one and the next 2, are going to be the core of what we talk about through the day-to-day. We're going to learn to really recognize what's going on. So what makes people a level 4? Moderate risk. Moderate risk, a chronic illness with mild exacerbation, mild progression of disease, or mild side effects. Now, how many people did you see yesterday that had at least one chronic illness that was not quite well controlled? All of those were level 4s. Every one of them. That's what a level 4 looks like. Because a level 3 looks like a stable chronic illness. If they have 2 stable chronic illnesses, that's a 4. You're saying, well, shoot, I don't have anybody with only 2 stable chronic illnesses. All my patients have 12 stable chronic. Okay. This is a 4, though. 2 stable chronic illnesses. If they have an acute illness with systemic symptoms, what are systemic symptoms? Fever, vomiting, diarrhea, weight loss, weight gain, sweats, chills. You know what systemic symptoms are. Acute illness with systemic symptoms make them a 4, make them a moderate risk patient. If they have a new problem with uncertain prognosis, and we always have a big mix-up about this during the day. This is an uncertain prognosis, not an uncertain diagnosis, okay? This is somebody with blood in the stool. This is somebody with a new breast lump. This is somebody that we're not sure if they're going to be fine or if they're going to be not fine, okay? If the 5-year-old comes in with cough, cold, and congestion, he doesn't have an unsure prognosis. He's going to be fine. He has an unsure diagnosis. So if they have an uncertain prognosis, that makes him a level 4. An acute complicated injury. It can be complicated by the type of injury, the mechanism of injury. It can be complicated by the type of patient. You know, if somebody falls and bumps their elbow, that's one thing. If they're also on Coumadin, that's another thing. If they got dizzy first, then fell, that's another thing. And so a complicated illness or injury makes it a level 4. Prescription drug management. I don't want to say 100% of the time, but if you do prescription drug management where you change or add or remove a medicine, most of the time that's going to push us up to a level 4. And somebody says, well, everybody comes to my door gets a prescription. That's not my fault. I don't care what you do. That doesn't necessarily make them a level 4, but it tends to put them up there. That's one of the more difficult ones we'll talk about. Giving additives with IV fluids, or pre-oping somebody for major surgery with no risk factors, or pre-oping them for minor surgery with risk factors. So what makes a level 5? It's almost the same template, except it's one step up in severity. High risk, or level 5, is a chronic illness with severe exacerbation, progression, or side effects. It's going to be an illness or injury that is life-threatening, or threatening to limb. Or if they have, insert word here, failure, this organ failure, that is life-threatening, limb-threatening kind of illness. If they have an abrupt change in neurologic status, they were fine and then they went goofy. They were fine, then they passed out. Abrupt change in neurologic status makes them a 5, okay? And so you're saying, so I just made them a 5. No, you didn't make anything. They did it to themselves. Giving controlled drugs by IV, morphine, stuff like that. We don't do that a lot in the office. Giving them IM doesn't do anything. It doesn't make them a level 2, 3, 4, or 5. But IV it does. Drug therapy requiring monitoring. This is not giving albuterol and watching their pulse ox. The specific examples of this in the book are giving adenosine, putting them on a dopamine drip. We don't do that in the office, hopefully. So this doesn't really count in the office. That's more of a hospital thing. A DNR. A DNR by its nature is life-threatening. Because of this discussion and the things we're saying today, you could die faster. So a DNR is a level 5 issue. And if you're pre-oping somebody for major surgery with risk factors or emergency surgery. So we've gone through these 3 slides. And let's go ahead and pass these out, Dave. So here's what I'm going to tell you. We've just about wrapped up everything you need to know right there. If you can master those 3 slides through the day today, we are going to learn to recognize what walks in your door. David is handing out a risk worksheet. And this is going to be your worksheet through the rest of the day. And I'll tell you what, like I said, I have 3 other providers that work with me. We leave these out on the counter because then they'll come out the door and they'll say, okay, Dr. Paul, I just saw this. Is this a 4 or a 5? And I'll say, let's look at the risk worksheet and see. Because almost everybody that you see, we should be able to pigeonhole into one of these categories. Now, if you look at the risk worksheet, at the top, I have red and yellow and green columns, and they go all the way down. For simplicity, red means high risk, means level 5 patient. Okay, it's like a stop sign. Yellow means moderate risk, which is a level 4 patient. And then green means low risk or level 3 patient. Do we have any extras of those worksheets, Dave, or those handouts? I might take one if there's, oh, okay, here's one. I got it. Thank you. Okay. So if we look at this risk worksheet right here at the front, this is what we're going to do to identify the patient that just walked in, and are they a level 2, 3, 4, or 5? And if you look here, it doesn't matter if they're internal medicine or pediatrics. It has nothing to do with this part. All we have to see is it acute or chronic problem? What kind? Okay, so let's take, for example, if I say, actually let's not, let's go to our first example. Let's listen here. Something happened. Okay, we're going to do 7 patients here. These are 7 patients we're working with. And what I want you to do is determine what is the level of risk. And we're going to do these at our table. Let me see where we're at. Oh, okay. It's not in the handout. Okay. So, here's what I would say. We're going to do these, and the first one we're going to work through together as a group. So let's see who it is.
Well, I've been coughing a lot, and last night I was running a fever up over about 102.
We already heard from Jerry today. So, look here. What is our level of risk? First off, is this acute or a chronic problem? Acute problem. I think most of us agree this is an acute problem. So, where in this acute problem, going from left to right, does Jerry fall? Anybody? What does he have? Okay, somebody said moderate. Why moderate? Okay, here's what we're going to see. My wife was a school teacher for a long time. We're going to use our words, okay? Whenever somebody says, why is that a level 4? We don't get to say, well, because they're pretty darn sick, aren't they? No. We get to say they had an acute illness with systemic symptoms. That's what Jerry has. He has an acute illness with systemic symptoms. He is a moderate risk patient. He should have a level 4 note written about him. Okay? That's going to be our thought process. So let's go to the next one.
Any problems, any side effects, anything like that going on?
Ever since I've started on this new medicine, I can't hardly eat lunch at all.
Okay, and I tell you what, they're on page 14. Go ahead and write Jerry 02 under the moderate risk section. Okay, because we just talked about that. Now at your tables, I want you to discuss for the next, you have 30 seconds. At your tables, where are you going to put KD05 when it comes to risk? Go. Yeah, she's having mild side effects. Mild side effects. So where does that put her? Moderate risk. Okay, that was an easy one. Let's go to the next one.
The pain medicine doesn't seem to work very well. I still have pain all the time.
Sharon 04. She said, pain medicine, it doesn't seem to work very well. I still am having pain all the time. So, talk about your table. And we're going to see what your table leaders have to say. Okay. How many tables would say this is a low risk, moderate risk, high risk? Oh, everybody said moderate. Why moderate? What do we have? Okay, we can say prescription drug management. What else? Okay, we have a chronic problem with mild or moderate exacerbation. Okay, how many here would say this is a severe exacerbation? We don't know that, you know. I'm having pain all the time. Yeah, if I had a nickel for somebody who had pain all the time, I would be an internist, actually. So, no, I mean, you know, how severe is severe? We'll talk about that as the day goes on. But looking at her, she's hurting all the time, probably mild or moderate pain. So probably we're having a chronic problem with mild exacerbation of her chronic problem, whatever that is. Okay, Teresa 04.
I've had a sore throat.
Okay, Teresa's had a sore throat. So let's talk about that. Acute or chronic? Acute. Okay, where would we put her? What words would we use for Teresa? Like I said, we don't know anything else yet. And I'll tell you, some patients you walk in and you'll say, well, this is a 3 or 4 depending on whatever this is. What we know, Teresa has a sore throat. Where does that put her so far? Okay, we have 1, 3, 1, 5. Okay, what level of risk? Low, moderate, or high? Why? Okay, we're saying she has an acute, uncomplicated illness. I would agree with that so far. Now, could that change? Sure, we can get more history. But Teresa comes in with just a sore throat. We're going to say, until we know otherwise, that's a low risk. So we can put Teresa 04 in the low risk category. And let's see what's next.
My left arm really hurts.
Okay, we're going to say she's not having an MI, okay? Okay. No, just, you internists, I tell you what. Okay, her left arm hurts. Her left arm hurts. Where does that put us? Low or moderate risk. If it's low risk, why? What would be the words? Okay, uncomplicated. Is it an illness or an injury? We're not sure. Is it arthritis? Did she? We don't care. Uncomplicated. So what would make her a level 4? Okay, if she was complicated, could be, and like I said, that could be complicated by the type of injury or illness or by the type of patient. What else would make her level 4? Okay, sure. I mean, if we could think of some weird thing where, oh my gosh, this could be bad disease number 27, then yeah, that could be it too. You know, she's got this joint pain and this rash and her ANA is 400 and, you know, okay, could be something worse. So, Cheryl 03, until we know otherwise, left arm really hurt is going to be low risk. That's where she's going to fall. So, left arm hurts.
Well, last night, my wife said she thought I was kind of low, and she said I was acting kind of goofy, and she gave me some orange juice, and it seemed like it got better.
Okay, Larry has diabetes, and last night his wife said that he got kind of low and gave him some orange juice, and he got better. So, what does he have? Chronic problem, diabetes with... Okay, we say 1 mild exacerbation. What else does anybody say? Okay, life-threatening. So what? So we say it's life-threatening, or what else? So there's a high risk. What else can we say? Abrupt change in neurologic status. Okay. So basically, Larry said, well, let's just listen. What did Larry say again?
Well, last night, my wife said she thought I was kind of low, and she said I was acting kind of goofy, and she gave me some orange juice, and it seemed like it got better.
Okay. Larry said, last night, my wife said I had a 99215, is what Larry said. Larry doesn't remember. Okay. This is, I got kind of low and gave me some orange juice, she says. Okay. Larry, yes, we could say abrupt change in neurologic status. We could say threat to life or bodily function. But the most accurate would be a chronic problem with severe side effects. Why did Larry get low? Because he had too much insulin. It's a severe side effect. It's what Larry had. Low enough that a diabetic doesn't remember is pretty low. Okay? That's a severe side effect. That's a 99215. Let's see what's next.
I already tried that and it didn't really help at all.
I'll tell you what, let's try one of these prescription nose sprays. I think that'll help quite a bit.
Okay, Ben has allergies, and we tried the over-the-counter thing, didn't really work. We're going to put him on a prescription nose spray. So, what does he have? Chronic or acute? Chronic. And how would we characterize it based on risk? Okay, somebody said moderate risk. Why? What does he have? Okay, somebody said prescription drug management. What else would make him moderate risk? Ah, very good. He's not having side effects that we can tell. He's having mild disease progression. Now, disease progression, let's go ahead and talk about this here. This is a good spot for it. Disease progression is not how far his disease has progressed since the last time he was here. That is not disease progression, okay? That may be an exacerbation. What disease progression is how far on the scale of this disease is he, okay? For example, we can have our asthmatic that takes PRN albuterol only, or he has an inhaled corticosteroid and albuterol, or he has that and Singulair, or he has those 3 meds and every other day prednisone, okay? That's disease progression. Now you have somebody that has bad disease, it's taking 4 drugs to control 1 disease, and they're totally stable from last time, doesn't matter. They have severe disease progression, okay? Our diabetic that comes in with a sugar of 120 is different if he had diabetes for a year versus he's had a kidney transplant and cataracts and he's lost a foot and his sugars are 120. That's still not exacerbation, that's severe disease progression. And so disease progression, one of the ways we characterize that is it is taking more to control him. Okay? 1, 2, 3, 4, 5 drugs of whatever severity. And so yes, he is having mild progressive disease because the first initial drug that we tried is not working. And now we've moved on to a prescription drug. Let's see what's next. Ah, that's the 7th one. Okay. So this is what we're going to do for a good portion of today, is we're going to learn to identify people by their level of risk. But when it comes to documentation, risk is nature of the presenting problem. That's what we've been talking about, is nature of the presenting problem. When it comes to documentation, we still have to talk about the rest of medical decision making. And that's what we're going to talk about here. And this is actually there at the bottom of this page. If you look down here, see where it talks about diagnosis, treatment plans, or data review. Let's finish our discussion on medical decision making. Now we've moved on to page 15. So, medical decision making, if we look at the slides before that, is number of diagnosis or management options, data review, and risk. And what we have identified is their level of risk. That's what we've just figured out, is they are what risk of patient. Now we're going to move on to what else do we need to write it. Just because we found out Katie is level 4 patient, now we need to know how to write a level 4 note. And so this is where we start. Diagnosis management options. We have minimal, limited, multiple, extensive. If I say somebody has 3 diagnosis or management options, where would you put that in this list? Anybody? Why? Because there's 1, 2, 3, 4, right? You know, that's what I think too. In fact, most people would put 1, 2, 3, and 4, but there's nothing in the book that says it. So I'm going to warn you about that now, but this is what I got audited. This is how most auditors I know. So if I have 1, 2, 3, or 4 diagnoses, then that makes it minimal, limited, multiple, or extensive. Okay, so that's one way. Let's say if we're talking about a level 5 patient, the biggest patient, level 5 patient, I'm going to need at least a severe number of diagnosis or management options, which means I need 4 diagnoses or 4 management options. Now I can't have 2 of each, that doesn't count. I need either 4 of this or 4 of these. So what are diagnoses? Well, of course, diagnoses are straightforward diagnoses, an established diagnosis. They have diabetes, they have hypertension. But in this place, this is where you would also put things like possible or probable or rule out. Now, if we see somebody for abdominal pain, we get to bill for abdominal pain. But if in your note you put they have abdominal pain and we need to rule out GE reflux and we need to rule out a hiatal hernia and it might be appendicitis or it might be a kidney infection or it might be a bladder infection or it might be, you put in those differential diagnoses, at least 3 or 4 of them, and you have fulfilled your requirements for a level 3 or 4 or 5 note. Okay, so if we look at this cheat sheet, and that's what we're going to go by today, look down at the right here, 99213. Right here it says 99213. It says I need at least 2 diagnosis treatment plans or limited data review and this low level of risk. And so here's what we're going to get at, is for a level 3 patient, you need at least 2 diagnosis or treatment plans. For a level 4, you need at least 3. And for a level 5, you need at least 4. I know it seems a little complicated. It's going to be easy after the next hour. So we have diagnoses. That's easy. What are diagnoses? Diagnosis is the list we have on the chart. What are treatment options? Treatment options is very specific to Medicare. Okay? This is what a treatment option is. It's a initiation of a treatment, a change of a treatment, including patient instructions, nursing instructions, therapies, medications, or referrals. Those are treatment options. And so I have to have at least 3 or 4 diagnosis or treatment options. So let's take an example of Ben. We just saw Ben. He had allergies. He wasn't responding well to over-the-counter meds. Now we're going to put him on a prescription nose spray. So we're saying that's a level 4 patient. A level 4 patient needs at least 3 diagnoses or 3 treatment options. So how many diagnoses does he have? Really just 1. I mean, he's got allergic rhinitis. That's about all we can say on him. So what are our treatment options? Well, first off, we put him on a prescription nose spray. That's 1. How can we get up to 3? Did we tell him anything else to do? Well, I probably said stay on your over-the-counter antihistamine. What else did we tell our people with allergies? Avoid exacerbating symptoms or whatever. What else? Avoiding triggers. What else? Okay, compliance. We can give instructions about medications. We can say, follow up tomorrow if you're not better. We can say, follow up in 3 months if you are better. We can say, look out for this, and if this happens, I want you to come back sooner. All these things that we do, we've done at least 3, I'll tell you that. It's easy to get 3 treatment options. Now here's the trick. What if I say, I want you to go get allergy testing? Yeah, that may be a referral to an allergist. Let's say I tell them, I want to go get some blood drawn on you. We're going to get a CBC, and we're going to see what your eosinophil count is. I don't do that because I'm a pediatrician, but let's say we're going to do that. Where does CBC fall into here? It doesn't. Treatment options have nothing to do with labs or x-rays or procedures. Okay, basically it's instructions. You're telling them to take this medicine or stop this medicine or do this therapy. Those are all treatment options. They do not have anything to do with labs or x-rays or procedures. That is data review. And I hate data review because this is the slide for data review, and that's the simplest I've ever been able to break it down. And it's an ugly slide. Basically, here's what it says. If you order labs and x-rays and procedures, then you've got enough data review to push them up to a level 4. But it's still not enough to push them up to a level 5. And odds are they've gone up to level 4 without your help from data review. And let's look, any kind of lab you order or review, it doesn't matter if it's 1 lab or 15 labs, you get 1 point for it, okay? Same thing with radiology, same thing for diagnostic tests like pulse ox or spirometry or EKG. We do a lot of those commonly, not all of them, but those kinds of tests we do commonly. But look at the rest of this. Discussing an unexpected test result with another physician, we don't do that very often. Independent review, we don't do that very often. Obtaining, reviewing old medical records, sometimes. Reviewing or summarizing old records or history from other than the patient, sometimes. The key on this data review slide is that rarely is this going to elevate your level of service at all. So we may see a point or a case where it does, but for 99% of our work, and it doesn't matter what kind of primary care you do or even specialty care, for 99% of the time, this will never factor into our decision making. So we're not going to spend a lot of time on it. Basically, we need diagnosis treatment plans plus risk. So data review, like I said, it's 1, 2, 3, 4. And again, medical decision making. Medical decision making is determined by 2 out of 3. We have diagnosis treatment plans, we have data review, and we have risk. And since data review is rarely going to come into play, we're going to focus on diagnosis and treatment plans and risk. And remember what risk is. Risk is the nature of the presenting problem. It's those things we've just talked about identifying. So let's talk about some common level 4 patients. If we bring these together, a 99204 or 99214 needs at least 3 diagnoses or treatment options. And that's we're going to have to get in our head all the time. This is key to writing a good note. If I see a level 4 patient, I better have 3 diagnoses or 3 treatment options. Okay? And that's what I do even with myself. Because sometimes I'll see a level 4 patient and I'm sitting writing my assessment plan and I think I only have 1 diagnosis. What's my plan? And I'm trying to come up with anything else I told them that would give me another treatment plan. But for level 4, you have to have at least 3 treatment plans or 3 diagnoses. And then risk. They have to have at least 2 stable chronic illnesses. They have to have a chronic illness with mild exacerbation, progression, or side effects. They have acute illness with systemic symptoms, or you've done prescription drug management. But if we look at those requirements, how many of our patients that we saw yesterday should have been coded as level 4? A ton. So is that, you're saying every time this comes up, I need to code that as level 4? Yes. Yes, I'm saying that. So I'll tell you what, level 4 patients are everywhere. If they're bad enough to come into the doctor, most of them have level 4 problems. Let's look at level 5 patients. They need at least 4 diagnoses or treatment plans. And I tell you what, somebody come in with a cold, and I guarantee you've told them at least 4 things. You know, encourage fluids, take your Sudafed. If you're not better in this many days, come back. And if you start having trouble breathing, do this. Otherwise, follow up at your next visit. Well, that's 4 treatment plans. So does that mean those people with a cold are level 5 patients? No, it doesn't. That means they have 4 treatment plans. So, and what about risk for level 5? A chronic illness with a severe exacerbation, progression or side effects, or abrupt change in neurologic status, or threat to life or bodily function. Those are level 5 patients. And I'll tell you what, even in my healthy pediatric practice, I have level 5s just about every day. I have 5 or 10 level 5s a week typically. And that's in healthy kids. So does that mean in your practice you're going to have low? Yes, you're going to have plenty of level 5s. Plenty of level 5s. I talked to a friend of mine about a year ago. He came to a conference. Haven't seen him since medical school. He was an internist, and we got through this. He said, oh, Paul, he said, I've never coded a level 5 in my life. And I said, why? He said, well, I'm afraid to. I said, well, how many of your patients now that you look back, I said, how many patients are not level 5s? He said, 20% maybe. You know, because that's what internists do. That's what they do. So that is going to be our place we start at when it comes to coding and documentation.
I've got a rash.
Oh, we're up to Katie already. Well, let's see. Is everybody here on the same page? Where are we? Okay, Katie. This is a template. It's similar to the template that's on the back of your risk worksheet. Okay, this is a template we're going to use. There's nothing magic or wonderful about this template. This is just one I've designed that we can work through and use as a worksheet through the day-to-day. Instead of having to write everything out by hand, let me walk you through this real quick. We have the patient name, chief complaint, history, present illness. We'll put that all up there in the top. Okay, and most of the time I've already written in there what she exactly said. Now you can add to that if you want. Down in the history section, we have review of systems. And let's say if you're going to do a review of systems, just check the box. Okay, since we can't talk to Katie, I don't want you to put in there denies, fever, chills, nausea, vomit. You know, we don't have time. So if you would have done a review of system, then you check off that box as review of system. We have medical history, we have family history, we have social history. Below that we have physical exam. And here's the other thing I tell you, as we start going through these, if you have normal physical exam, just circle the N. Or if you did the physical exam, if it wasn't normal, circle it anyways. Okay, that's how we're going to get through these notes quickly. But then the money part, the important part is down here. We have diagnoses and plans. And you will soon see that that is much more important than the history and physical. Now, not to doing medicine, it's not, but to documenting and getting paid. So we're going to grade Katie's note right here. So let's regress. Katie said she's got, well, let's see, what did she say exactly? Let's listen.
I've got a rash.
Katie's got a rash. So here's what you're going to do at your table. Katie's got a rash. Number 1, looking at our risk worksheet. What should be the level of service? Is this a 9921, 2, 3, 4, or 5? So number 1 at your table, and come to a consensus. What should be the level of service, number 1? And number 2, this note, as it's written, and you're auditing it, is it that level? All right, you have 1 minute. Go. Okay, has every table turned in their pre-test? Okay, if not, we need to give them to Dave. We've got about 20 minutes before our break. Let's talk about this. Okay, at your tables, hope we came to a consensus. What is Katie's level of risk from what we know about her? Low, moderate, or high? Does anybody say moderate? Okay, why moderate? Okay. Now we could say uncertain prognosis, especially if she had like a petechial rash or something like that, but probably it's still more the uncertain diagnosis. So, and that's okay. So let's go with low risk. Let's go with, this is a new rash, 99213. So what do we have in our note? History, patients here for complaints of new onset rash on arms. That's it for history. Physical exam, constitutional normal. Skin says contact dermatitis on arms and trunk. Diagnosis, number 1, dermatitis. Treatment plans, hydrocortisone, BID, over-the-counter antihistamines as needed. So let's look down here at our requirements for a 99213. So we've already met the risk requirement. We're saying this is what? Low risk, why? Uncomplicated illness. Okay, that's what we're going on, uncomplicated illness. We're saying low risk. So do we have at least 2 diagnosis or treatment plans? Okay, we have 2 treatment plans. We're going to do, I just said take over-the-counter hydrocortisone. We're going to say take over-the-counter antihistamines. Those are both treatment plans. Those are patient instructions or medication initiation. Those are both treatment plans. So we have 2 treatment plans. We don't also have to have 2 diagnoses. We need one or the other. So do we have a physical exam of at least 8 organ systems? Nope, that's because I was on the wrong line. How about 2? Okay. And how much history do we have there? Do we have 1 element of HP? Wait a minute, we haven't even colored that yet, have we? So that's what we're going to get into next. So we know Katie should be a level 3 patient. And we know we have enough medical decision making. We've got at least 2 diagnosis and treatment plans. We have a low level of risk. So now we've got to figure out, do we have enough history and physical? Okay, here's what I tell you. This note, as it's written, is fine for a level 3. This note will pass an audit all day long. Okay, this is a note I affectionately call a crap note. Okay, this is a crap note because if you wrote this out by hand, it is this big. It is a this big note, and you have very little useful information in there. And that's something we're going to talk about today. There is we have to put as much information in our notes as is needed to do good medicine. If somebody's reading our notes later besides us, or if we're reading it and we forgot, we better put everything in there that we need. But here's what we will tell you. When it comes to fulfilling the documentation requirements, we've fulfilled it right there for level 3. Level 3s are so easy to write, it's not even funny. And I will tell you, if you get audited, they're not going to look at your level 3s. They don't care about your level 3s. They want to see your 4s and 5s. But we've learned about medical decision making. Now we need to cover history and physical. So we're going to cover history and physical before the break, and then we're going to get into some examples for the next 3 hours. We're going to go through lunch with examples. Let's talk about history. And I know most talks start off talking about history, then physical exam, decision making. I want to start off with what I felt was the most important, which was nature of the presenting problem and risk, because that's going to focus our thoughts from the rest of the day forward. Now, how many here have ever been to another coding seminar anywhere? Okay, quite a few of you. For those of you that have heard me talk before, they already know this. The first time I went to a coding seminar was the last time I went to a coding seminar, because this nice lady spent an hour talking about history of present illness, and it drove me crazy. And so I ended up skipping after the first hour, and I don't know if the rest of the seminar was good or not. I just couldn't take it anymore. And so we're not going to teach you how to do third-year internal medicine. I'm assuming most of you know how to do a history and know how to do physical. We're going to go through what's needed, what is required so we don't get in trouble in an audit. So let's start with history. History is composed of chief complaint, history of present illness, review of systems, and then past family social history. So very simple. Here's what it is. A chief complaint is why are you here? We know that. It doesn't even have to say chief complaint necessarily. I don't ever put chief complaint on my notes. I put history of present illness. Patient is here for this reason. That's the chief complaint. We'd like for it to be in the patient's own words. That's fine. People say, well, can the nurse write it on there? Sure. Can the patient write it on there? That's fine. Can the doctor write it? Sure. Chief complaint, don't worry about. There better be something there really early that says why they're here. No, number 1. History of present illness. There are 8 parts of history of present illness. And if you have at least 1 part, then it's considered a brief history of present illness. If you have at least 4 parts, it's considered an extended history of present illness. You never have to have all 8. Okay, so what are the parts? Location, quality, severity, duration, timing, exacerbated, all the stuff we've learned that. And if you look here on your template, they're right here on the side in the green area. They are location, quality, severity, duration, timing, context, modifying factors, associated signs, symptoms. That is the 8 points. We never have to have all 8 points for coding purposes. Now, for medicine purposes, yeah, you may need all 8 points sometimes. And a lot of times for new problems, you've asked all 8 points a lot of the times. But for coding, 1 is brief, 4 or more is extended. So let's look at a couple of these. Let's listen to Ben.
Just lately, my nose has been running a whole lot, and it just feels like I've got like a rock lodged up in my sinuses, and it's terrible. I've been wheezing, and I can't breathe very good, and it's just a bad deal.
Okay, you have 30 seconds at your table. Do the check boxes on the bottom of page 21. I gave you the verbatim quote there from Ben. What of these that he said do we have? Location, quality, severity, duration. All right, 30 seconds, go. And you can talk about it at your table. Okay, let's see. Count up how many check boxes you have checked. How many here have 1, 2, 3, 4, 5, 6, 7. Okay, we have 4s, 5s, and 6s. Let's look here. Do we have location? What is it? Sure. Nose. Quality. What is it? Okay. Feels like a rock is typically quality. You can make a case for terrible, but actually terrible is severity. Okay? And we'll see. Often we'll get severity and quality confused. Okay? Severity, how much? Quality, how? Or how does it feel like or act like or whatever. Crushing pain is one thing. Severe pain is one thing. Severe crushing pain is both. So, and a lot of times you'll say, well, it could be quality or severity, but if it's one word, it's only one. So it doesn't matter which one. So we have quality like a rock. Severity is terrible. Duration. Now, is just lately a duration? Yeah. Yeah. How long is just lately? Okay. Maybe a few days. Maybe a few weeks. Probably not a few months or years. Probably not just today. It's several days. Okay. Yeah, we can make a case there. I agree with that. Do we have timing? No, timing is always every morning I wake up like this. Or after I eat, this happens, or whatever. So we don't have timing. Do we have context? Not really. Context is every time I see my mother, well, my stomach, no. That's context. Okay. We have modifying factors. Not really. Modifying factors are it gets better when I lay down, or taking Tylenol helps. Those are modifying factors. What about associated signs and symptoms? Okay, yes. So we definitely have 5. Now, someone wants to make a case for 6. I'm not going to fuss with you because it doesn't matter, really. We either have 1 to 3 or 4 or more. So we have an extended history of present illness right there. Let's see what Jerry O2 says.
Well, I've been coughing a lot, and last night I was running a fever up over about 102.
Okay, do we have location? What is it? Respiratory system, chest, you bet. That's a location. Quality. Yeah, a lot's probably severity, or it doesn't matter. It's one or the other, but not both. Okay, coughing a lot, or, yeah, okay, so we have quality or severity. Do we have duration? Since last night. We have timing, context, modifying. We have associated symptoms, fever. We've got 4 right there. I've been coughing a lot, then last night I was running a fever over 102. That one sentence is 4 elements of HPI. It is so simple. So, and the one other thing, let's listen to Jerry again.
I take medications for my cholesterol and high blood pressure and for arthritis.
Look back to the top of page 21. See where it says extended there. It says you have to have at least 4 elements of HPI or the status of at least 3 chronic problems. And so if you have a patient with at least 3 chronic problems and you comment on that, you know, they're controlled or not controlled. He's on this medicine, these side effects or no side effects. If you comment on their 3 problems or more, then you fulfill the requirements for an HPI, for a big HPI. So let's go to review of systems. Review of systems. I hate review of systems. I do, because review of systems cost me about $5,000 of my $7,000. Okay, because I failed to do review of systems. So, and my review of systems is, well, it's not the best, let's just say. There are 3 types of review systems. There is a problem pertinent, which is 1 system. There is an extended, which is 2 systems. And then there is a complete, which is 10 systems. Okay, now, it says in the CPT book by the AMA and in the Medicare guidelines, both, that you can put all other systems are negative. You can put that. Now, I will tell you, some states and some payers specifically say in their guidelines that you cannot. And so I know Texas Medicaid is one that I've come across. There says you cannot put this. The only way you get credit for it is if you list every system that you did. And so if that's what their guidelines are, you better follow their guidelines if they're a payer of yours. So like I said, these can be superseded by any local guidelines. But if we talk about review systems, we have 14 systems. And it's the main systems we talk about. ENT, respiratory, musculoskeletal, cardiovascular, GI, GU, skin, or all those systems. We know what the systems are. So let's look and see. Here's my review of systems.
Have you had any fever, cough, cold, congestion type symptoms at all?
That's it for me. That's my review of systems. Okay. Because most of the time review of systems is not necessary for my particular practice or patients. But that is not a review of systems. Let's go back to Ben. We've already heard about the rock. Listen closely.
Just lately, my nose has been running a whole lot, and it just feels like I've got like a rock lodged up in my sinuses, and it's terrible. I've been wheezing, and I can't breathe very good, and it's just a bad deal.
That will be the last time we hear from Ben and his rock, so that's good. So, look at your checkbox. Take the next 30 seconds at your table. I want you to check off every system that we've reviewed right there. Ready? Go. Okay, wrap it up. So, remember in review systems, we can review 1 system, 2 systems, or 10 systems. How many here say we've reviewed 10 systems? That's easy. 2 to 9. Okay. How many say 1? Okay. Here's the answer. We have reviewed no systems. This is history. Okay? This is what Dr. Paul learned for $5,000. Your review of systems is not your history. If somebody said, I've had cough, cold, congestion symptoms for 3 days, I have not reviewed the respiratory system. I have not reviewed, all the rest of the stuff. Now, if I put in my history, denies nausea, vomiting, diarrhea, constipation, abdominal pain, okay, that's a review of the GI system. Okay? Or if I put in review of systems, negative on GI except as above, then that's a review of systems. But when the patient says, I've had fever, we don't get credit for reviewing the constitutional symptoms, okay, unless you actually review the constitutional symptoms. And here's what I would tell you. When it comes, and we'll see why over the next hour or so, review of systems is absolutely required for new patients, or you're stuck at a level 2, okay? And believe me, I can vouch for that. Okay, it's absolutely required for new patients or you're stuck at a level 2. For established patients, you will rarely ever have to do a review of systems for your documentation, for coding. Now you may do it for other reasons and that's fine. But for established, you'll rarely have to do it. And we'll talk about why that is in a little bit also. But if you want to get credit for review of systems in an audit, you better have a